Welcome everybody to the Half the Sky Google Plus Hangout on Maternal Health. My name is Perry Peltz. I'm so glad everybody can join us. We have a wonderful panel discussion today. Just to give you a little bit of background, I am a journalist as well as somebody who specializes and learns a lot about public health. So the opportunity to really combine the two is very special to me. Why are we doing a hangout about maternal health? Well, that's a question that's really important. And the truth of the matter is, it's a topic that deserves a lot of attention. I want to give you some of the facts. Every 2 minutes, a woman dies of pregnancy-related complications. Now, that's about 800 women every single day, or about 287,000 women a year who die because of pregnancy-related complications. And most of those deaths could have been prevented with proven interventions. So it's a topic that certainly deserves our attention today. We have a great lineup with us. Edna Adan is the founder of Edna Adan's Maternity Hospital in Somaliland, where she and her fellow midwives have cut the maternal mortality rate of their patients to 1/4 of the national average. Her goal is to train and dispatch 1,000 qualified midwives throughout Somaliland. Kate Grant is also with us. Kate is the CEO of the Fistula Foundation, which raises awareness of and funding for the repair and prevention of obstetric fistula, a childbirth injury that leaves women incontinent, in pain, and ostracized. Fistula Foundation funds local partners at 38 sites, that's in 19 countries, completing more fistula repair surgeries worldwide than any other nonprofit or non-government organization. Christy Turlington Burns is also with us. Christy is the founder of Every Mother Counts, an advocacy and mobilization organization designed to increase education and to support and reduce maternal mortality. In 2010,
Can't hear you. Sound's gone.
It looks like we lost Perry.
It's back. Yeah, we lost Perry.
But the good news is, Edna, we haven't lost you. There's Perry.
I got cut off there. I'm back. Is everybody? And I think, as I was saying, that Christy Turlington Burns is with us. She is the producer and director of No Woman, No Cry, a wonderful documentary about the global state of maternal health. And welcome to all of our panelists.
Thank you.
Thank you.
Edna, let me begin with you. In your introduction, I said that you were able to cut maternal mortality rates of your patients to 1/4 of the national average. How have you been able to do that?
Well, I think it's a lot of hard work on many people from many sides. It's early response to early detection and response to complications of pregnancy, adequate knowledge on how to deliver a woman safely, preparedness to deal with complications that arise during delivery, and I guess a lot of blessings from upstairs as well. So, but then the main ingredient is having qualified birth attendants, midwives, to attend women when they're in labor and when they're having babies.
And I'm going to come back to you in just a moment, Edna, to have you talk about what a midwife is and how a midwife is different from a physician. But Kate, first let me go to you. Can you tell us, I think a lot of people don't know what obstetric fistula is. Can you explain that?
I certainly can. It's a problem that's been affecting women as long as women have been having babies. It just hasn't been on the global health agenda until about the last decade when UNFPA embraced it. In essence, it's what happens when labor is obstructed and goes unrelieved. If you're in this country and you have obstructed labor, I did, and I ended up with a C-section after 24 hours of labor. But if you're in a developing country, particularly a rural part of a developing country, and you don't have the midwife that Edna was talking about, or a doctor, for instance, to perform a C-section with that obstructed birth, the labor will go on for 2 days, 3 days, 5 days, until usually a stillborn baby is expelled. But the fistula is actually just a small hole, sometimes a slightly larger hole, created by that obstructed labor, and that hole basically creates a passage for urine and sometimes feces to basically leak through the vagina uncontrolled. So again, fistula is a result of unrelieved obstructed labor, and it's a birth injury that leaves women incontinent. The good news is with surgery, most of the time that injury can be repaired, and that's what the Fistula Foundation does, which is fund surgery at those 38 sites around the world to treat the injury once it happens. Although what Christy could talk about and Edna has devoted her life to is preventing the injury from happening.
All right, so Christy, let me bring you into the conversation. In the introduction, we said that 287,000 women die a year because of pregnancy-related complications. Talk to us, if you can, Christy, a little bit about the impact that has on society.
Well, I think most of us that are mothers understand that point most clearly. I think if we were to imagine being sick for a day, how our families and our societies can be impacted, but imagine if a mother dies at childbirth, that hole that is left unfilled and the sort of ramifications on her immediate family, but on the larger society as well. It's a triple effect that really, it doesn't stop once it starts. And when you meet families that have had a loss like this, you can feel that loss in such a powerful, palpable way. So again, trying to educate people about the fact that this is actually a problem, and the numbers have come down significantly, but then to sort of continue to educate people about how we can prevent the unnecessary deaths, largely unnecessary deaths.
Edna, let's go back to you. Talk to us a little bit about midwives. What is a midwife, first of all, and how is a midwife different than a physician, and how has this been so key to your success?
Well, as we know, a doctor is a very highly trained health professional, and it takes a long time, many years, and a lot of resources to train a physician and a doctor. To become specialized in obstetrics takes a further 4 or 5 years. When that specialist is trained, they usually require a hospital that is well equipped, where they can perform surgical operations, where they have diagnostic equipment and a support facility around them, diagnostic laboratory and so on, to assist them. A person who's gone through that much of training cannot function in a village where there is nothing, where there is none of the equipment and the supplies and the technical support that a doctor needs. So there is a shortcut, there is a quick fix. Most women who are pregnant do not have problems. They can go through pregnancy and childbirth without too many complications. And they require a person called a midwife, who is, again, a trained health professional, but it takes fewer years to train a midwife than it does to train a doctor. A midwife is trained to follow women during their pregnancy, monitor the pregnancy, the growth, the progress of the fetus, and when time comes to have that baby, to assist that woman through the delivery process by preventing damage to the mother and the baby. 70–80% of pregnancies are normal, and they would happen quite happily in the grandmother's house or at home. But there are 20 or 25–30% of women who do have problems, and these are the ones who need a surgeon or a doctor. But then who is going to identify those 20 or 30% who need further professional support? It's a midwife. A pregnant woman does not know what's happening inside her. She doesn't know how the baby is lying. She does not understand the proportion between her hips and the baby she's carrying. That's a midwife. You can train a midwife in 18 months. We've trained some in 18 months, and they're in isolated places where they're doing an excellent job. Places where a doctor would never agree to go and settle, because there's nothing around there to help a surgeon. We have women in villages, we have women in dispensaries, we have women in mother and child health centers, and they have made a difference in the lives of the community they are serving. The community approves and loves them, appreciates having them, takes their advice. Usually these midwives are from the community itself, so they know her, they know her family, they know that they can trust her, and she recommends that that woman be referred to another facility where her condition can be dealt with in a better way. They trust her. And the main factor is she is also a woman. Usually, well, most midwives are women. A few doctors are female in our part of the world. So there is that mistrust that also exists that midwives do overcome.
Thank you very much.
Midwives are the backbone
Let me move.
of maternal and child health services.
Let me move to Kate. Kate, Edna says that most women or many women don't have these problems, and certainly most women don't develop fistula from childbirth. Why is this such a problem in sub-Saharan Africa?
Well, there are several reasons. Probably the most specific is women in this country, women in the developed part of the world, in Europe and Asia, have access to emergency obstetric care. Even if you're an uninsured, undocumented woman in this country, if you go to a hospital here and you're in labor, let alone obstructed labor, that hospital will take you and treat you. It's the law. If, though, you're a woman living in a rural area, which most women in Africa live in rural areas, and you don't have access to one of Edna's midwives, let alone a surgeon to perform a C-section if that labor is obstructed, bad things can happen. Fistula is one of those outcomes, but as you mentioned in your setup piece, and Christy's documentary does a beautiful job of opening our hearts to that, there are many other bad outcomes that happen, including the maternal death, obviously. But back to fistula, it's lack of a trained surgeon to do a C-section with obstructed labor. I think about this often. I only have one child, a son, but I was at a hospital in New York, and that child was never going to go anywhere once they actually opened me up. His head was tilted even though they couldn't tell. All the pushing in the world would have never gotten him out. Would he have died? Most certainly. Would I have died? Potentially. Could I have developed a fistula? Potentially. It's just the lack of availability of those trained professionals. And as you all know, every woman that's gone through a birth, anybody's ever thought about it, labor is a time-sensitive event. You can't put off for a week or 2 weeks or a month getting that C-section.
Christy, let me ask you something. Both women talk about the fact that obstetric fistula happens also in a body that's not ready for childbearing, which raises the issue of prevention. So, Christy, what can be done to help prevent pregnancy in young girls?
Well, there's been a lot of work around the area of educating girls further. We know that if a girl stays in school longer throughout secondary education, for example, that the likelihood of her delaying first pregnancy and marriage, or marriage and then first pregnancy, is hugely impacted. So that's a real issue there, to keep girls in school, to keep them girls for as long as we can keep them girls. And then in addition to that, we have to look at nutrition too. A lot of these young women, and even women that are particularly young that are having obstetric fistulas, are malnourished their entire lives, and so they don't fully develop ever. You see the stature of a woman in sub-Saharan Africa, and is tiny, and it would be impossible to guess her age based on the size of her. And so in many countries there are government-designated guidelines which talk about stature and height and size, which help the healthcare workers and community health workers, and hopefully the communities themselves, to identify who may be likely to have an obstructed labor. But as Kate says, I mean, having access to emergency obstetric care is critical. And if we don't have the amount of time or the resources to get a young woman or a woman of any age to that care in a timely manner, then it really is, it's two deaths that we're talking about, not one or another.
Christy, let me also ask you a question. I'd like to bring our viewers into the discussion right now. And Andrea writes, in addition, I wonder how the panelists feel about the human rights approach to maternal health. What does it mean to them, and how would they like to see this approach improve over time? Christy, any thoughts?
Sure. Well, I came into this area after having had a complication with my own delivery 9 years ago. But all my education around public health and maternal health has been with the framework of human rights. Clearly, women's rights are human rights, and this is certainly a human rights issue, which is, I think, a great opportunity for us to get more people involved. This is not one of those issues that only involves mothers. This is an issue that involves every single woman. So the way that framework, I think, has impacted and made some significant progress in the last decade or so has really been, looking at women as individuals, counting them, prioritizing their place in society, the role of motherhood in all of the societies on this planet, and really addressing her needs, and treating them with dignity and respect at all times. To me, that's sort of the way in that I think frames it in a different way than it has been in the past.
Edna, Brooke writes to us, I'd like to hear Edna's take on just how effective qualified midwives can be to assist in obstructed labor and hopefully prevent fistula. So, Edna, that's a great question from Brooke. How can midwives help with this very problem that we're discussing?
Well, how a midwife can help is by recognizing that there is a potential danger to the baby and to the mother because of the size of this baby and the size of the pelvis of the woman who's carrying that baby. And if she sees that, she would refer this woman early enough to a facility. But then another preventive measure is not to damage the passage of the woman through which the baby is going to be born. Because, as we all know, there is that God-given elasticity for the natural passage through which the baby is born, which is elastic and it allows the baby to progress through that passage. But if there is a scar tissue, it becomes inelastic. It becomes rigid and it obstructs the progress of that baby before coming out. And it presses on the bladder, it presses on the urethra and the bladder because of that scar that has formed there and which is preventing the baby from coming out. So not doing FGM, not having a baby that's too big. If there is a disproportion, referring that woman to a doctor, to a place where she can be helped. These are all preventive measures. There is also a lot of ignorance that goes into it. But just today, we had a woman who the family refused, they waited for this or that other family member, and she had finally a cesarean section 12 hours later at 6 p.m. tonight. So that baby, of course, was much healthier this morning at 6 o'clock. That woman was less tired this morning at 6 o'clock. There was less pressure on the urethra this morning at 6 o'clock. So now, because of this delay, because of this refusal to have a cesarean section, we have to insert a catheter and leave it in just to make sure that she does not form a bladder, a hole between the vagina and the bladder. So ignorance comes into it as well.
Let's, as you just mentioned ignorance, Kate, let's talk about some of the social issues related to fistula. What happens, can you describe for everyone what happens to a woman who has fistula and how they can be ostracized and really removed from their communities?
Yeah, it's definitely a problem, a huge problem for these women. There was a wonderful documentary, which I want to just put in a quick plug for, because you can watch it for free online. It's still streaming on the PBS Nova website, called A Walk to Beautiful. Mary Olive Smith's masterful film that won Emmy for the long-form documentary the year it was up. It's incredible, and it talks about, or it describes the life of 5 women with fistula and their journey to beautiful, which was their hopeful recovery through the Addis Ababa Fistula Hospital. But it also gives you a really moving window into what it's like to be an incontinent woman living in a rural area where you have a dirt-floored hut, where there's no depend pads, where there's no running hot water, where you can cleanse yourself. Just the problem of basic hygiene ends up being part of what ostracizes these women. also because, again, you're dealing with women that are in remote rural areas, often illiterate, and in communities of women that are also illiterate, there's a lot of misinformation about what actually caused the fistula. Not that she was, as Christy talked about, potentially an undernourished girl child who developed into a stunted woman with a small pelvis who potentially had a child early. So these things had happened to her for no fault of her own, and then has this obstructed labor that leads to the fistula. So that the injury to her soul and her heart from losing the baby and ending up with the fistula is then compounded often by the lack of awareness of actually what created this problem, and the notion that somehow she brought it on herself, if she was cursed or if she'd done something bad. So there's wounds to, again, sense of self, emotional well-being, etc., in addition to the profound physical wound that a untreated fistula is. The good news, though, again, is that with treatment, many of these women are just incredibly resilient. I mean, Edna's treated them in her hospital. She could give you very moving examples, firsthand experience of women who have been cured, received treatment, gone back to lead productive, high-quality lives. So what amazes me about these women is often just how incredibly resilient they are. You think of what they've gone through, you know, extended labor, loss of a child, incontinence, and then having to usually go to a large city where they don't live and maybe don't know people to go through surgery for treatment, and yet they bounce back. It's incredible. I mean, Edna could probably talk about that again in more
Anything
detail.
you want to add to that, Edna?
Yes, I do. I think one of the most rewarding thing is when we have a woman who comes in with a fistula and who is repaired and goes home and heals, goes back to her husband, and a year or two later comes back to us pregnant with a healthy baby, and we can do a cesarean section and place that baby in the arms of that mother who never thought she would ever have a normal life again, who never thought she would ever be happy again, who's no longer leaking, who's not smelling, who's not embarrassed, who is not being ostracized. And that is one of the greatest gifts in life, to see a fistula repaired, because it really is a very humiliating situation for a woman to be leaking. And of course, the Fistula Hospital, the Fistula Foundation, and Kate has helped us to build an operating theater and sends us surgeons once or twice a year, where we call women on the radio. They come from all corners of Somaliland to have a repair of fistula free of charge. It's a great service that we not only provide to the women who need it, but also a great satisfaction to us and a great appreciation to what the people are doing in support of the women with fistula. And thank you on behalf of these women.
Christy, anything that you'd like to add to that?
Yes, thank you. Yeah, I would say that these women are incredible advocates themselves, and I've seen a number of programs. I mean, essentially they are the survivors of maternal mortality. In the U.S., we call those cases near deaths. But internationally, these are women that have had obstetric fistula, and many of them their lives have been restored and improved, and the stories are absolutely incredible. And so seeing how they can be so useful in their communities as educators, as community health workers in their own right, has been a great opportunity for their healing process, but also for the young women that live in their communities who would otherwise not know about obstetric fistula.
Edna, let's move on from fistula. We've talked quite a bit about that. Let's talk about female genital cutting. It's prevalent certainly in many parts of the world. How does that affect women's reproductive health?
Well, as I said, it causes a lot of damage at the time of the operation itself. It can cause infections. Cutting away human flesh is always something that leaves is harmful. So if the child, the girl, the 7 or 6 or 8-year-old girl does not die as a result of the operation itself, she will grow to become a woman who one day will get pregnant. And as a result of that pregnancy, she will have to deliver a baby through that passage, which has been so mutilated and has been so damaged. So that is, apart from the infections and the bleeding and the interference with the normal body secretions of a woman, and it's the damage at the time of childbirth. It's also emotionally traumatizing. It's a very painful thing. It's something that should not happen to girls. It's something that is usually performed without anesthesia. And it's a very physically and emotionally traumatizing procedure that has no place it has no place as far as religion is concerned, because Islam forbids it, is against it. It has no place in medicine because it is harmful and damaging. It has no place to prevent promiscuity or to preserve virginity, because it does not. It's the upbringing of that girl that protects her morals and her virginity. So female genital mutilation has no place in this day and age. It is a harmful procedure that should be done away with. And then I've been talking about it until I'm blue in the face, but I'm glad that the UN has now passed a resolution. But then there is no place for complacency. The UN has passed many resolutions in the past. It has not stopped the practice. It's the education of the traditional people who practice it, who need to be convinced, and who need to be counseled, and who need to be educated against the damage that they are causing their daughters. So it's a very slow, a very stubborn process, but thank goodness the world is joining efforts to try to ban it, also through the United Nations.
And Edna, I think that when
the little woman in the village doesn't know about UN resolutions. She will still go and cut her little granddaughter until we educate her about it.
And we will all talk about it until we are all blue in the face. You're absolutely right. This is an issue that we all need to keep talking about until it does go away.
Certainly, community health workers who are empowered with education and information and some tools to be able to address some of the health concerns for women in more rural communities. This is where the relationship and the trust starts to be built, and then they can also be the link then to more to further educated people, such as midwives, such as obstetricians, or doctors in other areas if they are needed down the line. So it's a really important workforce, and something that I've seen incredible things in Ethiopia done with through the health extension workers, and other countries where this has been, it's gaining momentum. I think there's so much we can do in almost any country with a mid-level provider that luckily is gaining some traction.
Kate, let me ask you, for everybody who's watching here today, what can people do to help? I think that so often we feel that these problems are far away from us. What would you recommend that people can do to help?
I'd say the first thing is maybe the easiest, which is being aware that there's even a problem. So much of U.S. philanthropic giving and attention goes to U.S. problems, which is understandable. So it's really sort of awareness is probably in some ways the easiest thing to do. For those who want to go a step farther, we try to make through our website, for instance, the ability for people to send links to our information to their friends and colleagues. For those who want to do more, we have a Circle of Friends program. We've had everything from a middle school girl holding a small bake sale to large dinners on our behalf, and we really leave it up to individual donors and folks to get involved in ways they want. The documentary that I was mentioning earlier, Walk to Beautiful, as well as the wonderful work that was done by the Half the Sky team, and Edna was the star, a beautiful star of the maternal mortality section of that. You are, you're gorgeous. You're just an inspiration.
Oh, come on.
In so many ways. I spent a week with you. I know you're the real deal.
And you know what my mother says?
Always.
Just say thank you.
Just say thank you. Part of her beauty is her humility, but I'll tell you, she's a force. Anyway, I could go on about Edna for the whole hour and then some, but I'll stop it. But just to say
we got better things to do, Kate.
Well, hopefully opening hearts, minds, and wallets for you and other people. But again, I think creating awareness within your friends and people who share your heart and your vision of the world, a world where women are taken care of, their children are taken care of, that's a huge step. It sounds so basic, but if we got another dollar out of 100 going to maternal health a year, it would be a big step, let alone another $5 out of 100. So creating awareness that there's a problem, that people can engage to do something. Again, on fistula, we have sites around the world, in most of them in Africa, 3 in Asia, Afghanistan, Pakistan, Nepal, Bangladesh, actually 4 in Asia. So you can check out our website, but we've had some wonderful volunteers that have become board members for us and continue to stay engaged. So soup to nuts, there's a range of opportunity.
Edna, a question for you from Meg Rogers. Does Edna think the UN ban on FGM can have real impact?
Well, I think it will have an impact to mobilize the international community, which I hope will generate resources to be able to reach the grassroots communities. Because these are the people who practice it, who believe in it, who have been practicing it for generations, and who need to be convinced to do away with it. We've all attended so many conferences in most capitals of the world. We debate it, we talk about it, we make resolutions, but little old grandmothers are still doing it. And that's where we need to put our focus, going down to the village, to the grassroots, to the uneducated, to the unenlightened, to the one who wrongly believes that she's doing the right thing for her granddaughter. So it's grandmothers and grandparents who we need to aim at. So I hope that the UN ban is one step forward, will convince governments and decision makers in the countries where the practice is prevalent to allocate resources and give attention to this very, very serious human rights violation that FGM is, and which is perpetrated against every girl in the countries where FGM is practiced. Women have a right to have a body that is undamaged and remains as God had created. Women's bodies have been created to bear children, and it should not be damaged. And I think we need to go down to that village. I will repeat that 100 times. And we need to also involve fathers, because very often fathers are never consulted about it. They're told that this is a women's affair, but little do they know that this girl is being damaged for the rest of her life. I don't know what else to add to it, but we must mobilize more education for the people who are ill.
Meg, thank you very much for that question. I should have also clarified FGM stands for female genital mutation. I'm sure everybody's aware of that, but just in case. Christy, Edna put such a fine point on the need to educate. What would you like people who are joined with us today to know? What's the one thing that people can do to try and begin to make a difference?
Well, I think, like Kate was talking about before, I think giving the public an opportunity to participate in creating solutions for women around the world is a really important thing. When we started Every Mother Counts, I remember that was the goal, really, was the idea of this is a conversation that's been happening, but at such a level that everyday citizens are being invited in. And so trying to give more opportunities at every level to learn and then to engage. And that can be in a number of ways. And when we count our advocacy and mobilization by actions, and an action can be anything from writing a blog to sharing their own story where they can make that connection with another mom, or in really highlighting the important work as Happy Sky does so beautifully, that Edna does, that Molly Melchin does with the organization Toe Stand to address FGC. It's so important that all of these issues are interrelated and connect and link up. And so as much as we can share those interlinkages, and as much as we can work together as small organizations, large organizations, to support the work of each other, that's also really important. And I think the public finds a lot of meaning in our showing that example.
I can't hear.
No sound.
Oops.
Sorry about that. Edna, can you hear me now?
But now I do, yes.
Very good. Edna, quick question for you, because we're going to wrap up in just a couple of minutes. But one of the people who's joined our Hangout today asks, if it takes 18 months to train a midwife, how long will it take for you to mobilize the number of midwives that you need to get the job done?
Oh my God. Well, if we have the resources and if we can start in many training schools throughout the country, because we cannot do it in just one place, if we can start a training in 6 training schools in Somaliland, and each one can train 20 to 30 or 40 midwives at a time, it would take us 6 years. But then the resources have to be in place. The trainers must be trained first. At the moment, we're training 40 girls, and it's going to take us 18 months or 20 months to train them. Until we get them out of training, we will not be able to take a new lot, and that will also depend on whether we have the resources to train a next lot as well. So it's very slow, and I wish we could accelerate it. I wish we could do it faster, because women are dying every day that there is no trained birth attendant, no trained midwife to attend to them. So time is of essence. It should be something that is carried out as a topmost priority, because none of the Millennium Development Goals to protect women during childbirth are going to be met if we do not have midwives in place.
Edna Adan, the founder of Edna Adan's Maternity Hospital in Somaliland, Kate Grant, the CEO of the Fistula Foundation, and Christine Turlington Burns, the founder of Every Mother Counts. Thank you to all of you. I want to thank all of our listeners, our viewers, I'm sorry, I'm used to doing a radio show, for being with us today. We really appreciate it. Thank you to Half the Sky and the Half the Sky movement, and to Google Plus for hosting this wonderful Hangout today. And remember, we can all make a difference when it comes to improving maternal health, and the first step starts with getting the word out. If you haven't seen the documentary Half the Sky, or if you have seen it and you want to watch it again, the documentary Half the Sky, Turning Oppression into Opportunity for Women Worldwide, will be rebroadcast, and that's on February 11th and March 4th at 10 p.m. Eastern Time, so check your local listings. Again, February 11th and March 4th at 10 p.m. Eastern Time. Also coming soon, an easy way to support the Half the Sky movement on Facebook. They're launching an adventure game that raises awareness and funds to empower women and girls across the globe. So that makes a real impact by unlocking challenges and sponsored donations in the game. So stay tuned for updates about that. And thank you again, everybody, for being with us. We hope to see you on the next Google Plus Hangout.